Welcome once again, and we are going to start with the second part of our prostate cancer lecture. And I hope you can see the screen, right? So before we delve into the second part, let's look at what we did in part one. So we looked at the anatomy and histology of the prostate gland. We looked at the pathophysiology, epidemiology, germline mutations, prognosis, clinical presentation, physical examination, of which the digital rectal examination was the most important. And we also reviewed the workup for prostate cancer, and we had a discussion on prostate-specific antigen. So with this background, now we are going to start this second part in which we will discuss the use of MRI for prostate cancer and prostate biopsies, and we will discuss in detail the Gleason score with the help of an analogy. And we will also have a quick look at risk stratification of prostate cancer. So let's start with this MRI. The use of MRI is increasing in certain clinical scenarios that are related to prostate cancer. So the utilization of MRI to assess for lesions concerning prostate cancer has recently increased in several clinical scenarios that include prior to prostate biopsy to make a decision whether to go ahead with the biopsy or not. And then active surveillance. Active surveillance means that you have a high suspicion of prostate cancer, but you don't start the treatment for prostate cancer. What you do is that you follow up the patient and you keep on doing surveillance, which includes MRI, and that sometimes also includes repeated prostate biopsies. Then to make a decision of surgical or local therapy planning, then patients with prior negative prostate biopsy and persistently elevated prostate-specific antigen. So these are the uses of MRI, and what we do is that lesions in the prostate that are detected on MRI are assigned a PI-RADS scores, which is done, of course, by the radiologist, and PI-RADS stands for Prostate Imaging Reporting and Data System. And what the radiologist then does is that he overlays the MRI images over the images obtained using ultrasound, and then that would help us in targeting the specific areas of the prostate gland for obtaining biopsies. Although we obtain a number of biopsies from different areas, and also remember that the most common region of the prostate, where 70% or of the prostate cancers arise, is the peripheral zones of the prostate gland. So prostate biopsy, a prostate cancer identified on screening is confirmed by biopsy. So the biopsy is the only way in which you have a confirmed diagnosis of prostate cancer, although it is almost concerned when you do, almost confirmed when you do other investigations, but still we have to obtain a biopsy for assigning a Gleason score or assigning a grade to the prostate cancer. And then we can predict the prognosis, and we can do risk stratification and decide a treatment. So initial prostate biopsies followed a Sextant 6-score protocol, and they were utilized in many of the early studies, but this had certain problems because, in 6-score means you're obtaining 6 core needle biopsies. But the sensitivity of the 6-score biopsy was suboptimal. Therefore, now most of the urologists and pathologists, they obtain a 12-core biopsies, which means they obtain 12 small samples from different regions of the prostate gland. In spite of these improvements, ultrasound-guided prostate biopsies fail to identify 20 to 30% of cancers, or they undergrade the other cancers, right? So we still have problems, although this is the best confirmatory test for prostate cancers. So for several decades, prostate biopsy has been performed via a transrectal approach utilizing ultrasound guidance. So this is known as TRUS. TRUS stands for transrectal ultrasound. But this transrectal approach has got certain problems. It is associated with adverse effects like rectal bleeding or hematuria or urinary tract infections. So now we have a better alternative, which is known as transperineal prostate biopsy, that has demonstrated promise in reducing the several of the risks associated with transrectal biopsy. So we do it under local anesthesia, and what you see over here is that an ultrasound probe has been placed in the rectum right next to the prostate gland, and that would guide the urologist to the appropriate places for obtaining core biopsies. All right. Now, I'll show you a schematic view of the prostate gland, and I'll show you how the biopsies are obtained. So this is what we already mentioned. Transrectal sextant biopsy involves 6 cores from the parasagittal planes on the right and left sides of the base, midzone, and the apex. That is what most of the pathologists do. For example, this is the bladder and the seminal vesicles, and this is the prostate. This is the base, the mid zone, and the apex of the prostate gland. This is the right side and this is the left side. So what the pathologist does in sextant biopsy is that he will obtain 6 cores, one from the apex, one from the mid zone, one from the base on the right side, and same on the left side. But as we already mentioned, that the results are suboptimal, and we miss a large number of cancers by obtaining just 6 biopsies. So now we have another procedure which is known as extended biopsy. The optimal extended protocol includes 6 standard sextant biopsies with additional biopsies, and most of the times they now take 12 biopsies, and the other 6 biopsies are taken more laterally. And here is how it is done. So these 6 inner ones are the normal 6-core sextant biopsies, and more laterally we have obtained 6 more biopsies. But we said previously that even then we miss 20 to 30% of cancer. So some people, they obtain saturation biopsies, which means that the number of cores is 20 or more than that. But obviously with larger number of biopsies, there is a higher risk of complications like bleeding. So here is saturation biopsies. You're almost obtaining cores from every area of the prostate gland, including base, midzone, and apex. Okay, right. Then histologic findings. Now, although when the pathologist he prepares his slide from the course, the 12 course that he gets from the urologist, there are certain histological findings which are still not seen in the slides that he prepares from those course. So what he basically looks at when he prepares his slide, when he stains the course or the tissues after slicing them, he looks at the change in the glandular architecture represented by Gleason score. And this is currently the most widely used histologic parameter. And the Gleason score does not cover all histologic changes that can be observed in prostate cancers. And those other changes, they include changes in the cell and nuclear morphology. Well, the pathologist is able to see the changes in cell size and cell shape and the nuclear to cytoplasmic ratio, but maybe he may not be able to observe the loss of nuclear membranes and other molecular changes inside the cell. DNA aneuploidy, that happens in most of the cancers. The cancers have an extra or missing chromosomes, which basically means that the chromosomes do not have a multiple of 23 chromosomes. Like, euploidy is that we have 2 sets of 23 chromosomes. So we have 46 chromosomes, but because the cancer cells are dividing very, very rapidly, the chromosomes are not equally divided between the daughter cells. So one cell may have 69, 96, or 67, 94 chromosomes. So if they are not a multiple of 23, we call that aneuploidy. and perhaps aneuploidy, whether it is good for the cancer, whether it gives them a survival advantage or not, we do not know exactly, right? Then we cannot know the neuroendocrine differentiation in by looking at the biopsies. Sometimes the cells have lack of androgen receptor that makes them more aggressive and more resistant to treatment. And vascularity, hypervascularity is associated with higher tumor grade. And in addition to these histologic changes, we have a couple of other histologic changes which are not basically cancers. They are known as precursor lesions. So prostatic intraepithelial neoplasia, which is treated as a benign condition, and atypical small acinar proliferation. Again, it is not treated as cancer and it warrants subsequent biopsies to see whether the cancer has developed or progressed. Or we can do other tests like CT scan, MRI, and PET if that is available. So the bottom line is that Gleason score is quite reliable. It has got certain deficiencies, but it is a good indicator of the presence of prostate cancer and the aggressiveness of the prostate cancer, although we now have a new grading system, which is again based on Gleason score. So let's look at Gleason score. What are we trying to determine in Gleason score, or how we obtain a Gleason score, all right? So we look at, as I said, we look at the patterns of the glandular architecture in the prostate gland. So we have got certain patterns. We have got 5 patterns, and we assign them a score of 1, 2, 3, 4, 5, right? These are the points that we give. So pattern number 1 is the cancerous prostate closely resembles normal prostate. The cancer is well differentiated, so it is not a very serious condition. Pattern number 2, to which we assign a score of 2, or we give 2 points to this pattern. The biopsy still has well-formed glands, but they are larger and have more stroma between them, and they are something between moderately differentiated and well differentiated. Then pattern number 3, the tissue still has recognizable glands, but the cells are darker and some cells are invading the surrounding tissue, and this is now moderately differentiated, and this is where we start worrying about the diagnosis of prostate cancer. Okay, this is where it is almost confirmed that the patient has prostate cancer, albeit it is an early stage and not very aggressive cancer. Okay, then pattern number 4 is poorly formed glands which are fused or cribriform. Cribriform means they have got holes in them. A large number of cells are invading the surrounding tissue, and this is poorly differentiated. Then pattern number 5, it does not at all look like prostate tissue. No glands are seen. All we have are sheets and cords of cancerous cells and necrosis all around the area which is cancerous. In a biopsy specimen, it is not necessary that the 100% of the cells in that particular core will be cancerous cells. So whatever the percentage of biopsies involved, we see these type of cells, and also in the next surrounding tissue. All right. So now what I'm going to do is I'm going to explain with the help of this analogy what happens in these different patterns that I've just shown you, right? So let us pretend that you have a rose garden, and you've got all these beautiful red roses in your garden, and that is analogous to a healthy prostate tissue, and all these flowers and these roses, they represent the healthy glands or the healthy acinar cells. So this nice looking rose is like a normal prostate gland or a normal acinar cells in the glandular tissue, right? So this is what happens. This is your pattern number 1. This is a healthy rose, and this is what you see in your garden. There are some flowers that are now looking like this. Okay, so this is analogous to pattern number 1. this is not too bad. You're not too worried about this garden. Some areas of your garden have got flowers or roses like this, so you assign it a score of 1. Then one fine morning you go to your garden of roses, and what you see is that now you have got a more sort of D-shaped roses, and they are analogous to second pattern that I'll explain to you in the next slide. And you're still not too worried, because maybe they will, when these roses, when they die or when they go away, you will get back these roses, but they are not too bad. Okay, you're still not too worried, although in certain areas you do have these not very good looking roses. Now, then what happens in your garden is that dead roses starts appearing, right? And petals are falling off those roses, and with the wind, they are spreading in different parts of your garden, right? So now your garden in certain areas have got roses like this. Now you are worried. And this is analogous to pattern number 3 of your Gleason score or Gleason pattern, all right? Then what happens to your garden is that now you're getting things like that in certain areas of the garden. Now, in some areas, you'll have things like this. In some areas, you'll have healthy roses, but in certain areas, you are getting some material like this, which is like compost. You can tell that it came from roses because the material looks like the petals of roses, but they are definitely not roses. Okay, so this is your pattern number 4, analogous to the 4th pattern in the Gleason score, and the cells are fused and cribriform, and we'll have a look again. Now, this is what happens in your 5th pattern. Certain areas of your garden don't have any roses at all. What they have are cactuses, these thorny cactuses. They have replaced a certain area. Say this area of your garden has now only cactuses over there. So this is analogous to the 5th pattern that you get, which are just sheets of cells. So let's have a look at them once again. Here I'll show you the Gleason pattern, and this is what you see in the biopsies. So you have got 12 cores, and you're looking at each core one by one. You have stained them, you've prepared your slides. So here what you see are cells which are like small uniform glands. Not too bad. They're not as good as the normal prostate glands, but you're not worried. You assign it a score of 1. So pattern number 1 is the cancerous prostate closely resembles normal prostatic tissue. The cancer is well differentiated. And in the second pattern, where the cells are a bit, D-shaped and not at all like these healthy roses. So this is your second pattern, and in terms of the cells of the prostate glands, or there is more stroma between the glands. You see the cells are bigger, and these green areas represent the stroma. So there is more stroma, if you compare it with this one, but still you give it a score of 2, and you're not too worried about this. So pattern number 2 is the biopsy still has well-formed glands, but they are larger and have more stroma between them. Now they are moderately differentiated. So what you see on this side is that we are progressing from well-differentiated to moderately differentiated, all right? So in this third pattern, we have dead roses, but still they are roses. You can tell they are roses. Their petals are falling out and they're spreading. So in terms of the glands, there is distinct infiltration at the margin. So the glands are more distorted. They are still recognizable. They are moderately differentiated, and the cells are now breaking through the basement membrane. They have invaded the basement membrane, and they are infiltrating the adjacent stroma. Now we go, and what we describe is that pattern number 3, the tissue still has recognizable glands, but the cells are darker, and some cells are invading surrounding tissue, and these are moderately differentiated glands. Now this is our pattern number 4, where the roses are they are gone. You can tell that this material came from roses. Now, what you see in the biopsy is that there are irregular masses of neoplastic cells with few glands, okay? So pattern number 4, poorly formed glands, fused or cribriform. A large number of cells are invading the surrounding tissue, and the glands and the cells are poorly differentiated, which means they don't look like the normal prostate glands or the normal acinar cells. And this is our fifth pattern. In certain areas of our garden, the roses have totally disappeared. And what we have are cactuses. Okay, this is how our garden originally looked like, but something has happened. And what you have is cactuses, which are analogous to these cells that you see in the biopsy. Almost no glands. There are sheets of cancer cells. They do not look like prostate tissue. There are no glands. There are sheets and cords of cancer cells. There is necrosis in those areas where you have got these types of glands. Okay, so these are the 5 patterns that we have in cases of cancers. The first 2 are not dangerous. We don't count them most of the times, and even if you count them, they will not total up to 6, because according to Gleason grading system, if you get a score of less than 6, it is not considered as a cancer, and even 6 is not aggressive. It is very sort of indolent cancer. It is progressing very, very slowly. It may remain there for the whole life of the person. He will not even come to know about his cancer, and he will die of some other cause. Okay, so let us see how we assign a Gleason score, right? We have given these points to these 5 patterns, and now let us see, based on these 5 patterns, how we assign a Gleason score. So this is here I'll show you the Gleason score, and here we have what we see in the biopsies. So you assign a score of 1 if the cells are like this, analogous to rows of this type in your garden. You assign a score of 2 with this. If you see in your biopsy cells like this or cells like this, you don't count them most of the times. Even if you count them, you will not get a score of 6 in Gleason. But now you get a core biopsy, and when you look at it under a microscope, what you're seeing are cells like this, and you are just seeing one pattern. Okay, so what you will do is that these cells are recognizable and uniformly distributed. Glands are seen all over the cancer. So you assign it a score of 3 plus 3. You always give 2 scores, right? 2 points, because you're seeing only one pattern. This is your biopsy. Obviously, this is not a real biopsy. This is just to help you understand what we see. So what you see in this biopsy is that predominantly we are seeing a pattern like this. Very few cells are, or many cells are healthy, or you are seeing this pattern or this pattern. You don't count them. If you see a pattern from number 3 onwards, you only count those patterns, because you are seeing only one pattern. You will give it a score of 3 plus 3. All right, so your score in this biopsy core is 6, and that is positive for the diagnosis of a cancer. Now, in your next biopsy, what you see is that the most predominant are well-formed glands, which are these ones, and the second most predominant are poorly formed or fused and cribriform glands, which are these ones. So because these are more predominant, as I've shown you in this, another schematic view, not a real one. So the most predominant or the most common pattern is this one. So you will first write 3, and the second pattern that you are seeing, which is less common or less predominant, is the pattern number 4. Because this one is more common, you will write 3, and then you will write 4. So your score is 3 plus 4. Your Gleason score is 7. Now let us go on to the next pattern, what you have in another biopsy code that you are looking at. The most predominant are poorly formed fused cribriform glands, which is pattern number 4. And the second most predominant are well-formed glands, which are pattern number 3. And now you have given a score. Again, the score is 7. This is how your biopsy looks like. The most common pattern that you are observing is this pattern number 4. And the second most predominant is the green one. Don't count these 2, okay, when these patterns are present, because this is the most predominant. You write 4 first, and then you will write 3. So your score is now 4 plus 3. Obviously, they're both 7, but this one is more aggressive than this one, because it has got a larger area in the biopsy that has this type of gland. So this is a bit of a problem in the Gleason scoring system. They are both 7, but this one clearly is more aggressive. Now let us go on to the next pattern, which is most predominant are poorly formed fused cribriform glands. No other pattern is seen in the cancer, right? So this is how your biopsy looks like. All you have is just one pattern. The other two, these two you don't count. Because you have got only one pattern, so you will count it twice. Your score is going to be 4 plus 4. So your Gleason score is 8. You can have other combinations of these two depending upon which one is more predominant. But now your Gleason score is 4. And then you go to the 5th pattern, another biopsy code that you are looking at, and you see that 30% or 40% or 50% of the area of the biopsy has this type of the cells: necrosis, cord, sheets, solid nests, single cells, with or without poorly formed glands. Okay, so just cancer cells, and they do not at all look like the normal glands, and they are poorly differentiated. And this is how it looks like, right? You have this pattern and this pattern. Because this pattern is more predominant, you'll give it a score of 4. You'll write 4 first, plus you'll have this is the second most common pattern, so it is 4 plus 5, right? So your score is 9 now. Here is another pattern. You see just one pattern. This pattern, no other pattern. They are normal cells. Okay, you can take them as normal. So now, because you have to give 2 scores, so you'll write 5 plus 5, okay? Because you're seeing one pattern, so you'll count that twice, okay? Now your Gleason score is 10. So this is how you assign a Gleason score, and that shows the aggressiveness of the cancer. But because of these problems, previously we used to group Gleason score 8, 9, 10 as one group, but again, clearly this group is more aggressive than this one. So now we have got a new grading system. In 2014 and 2019, international multidisciplinary conferences were convened to revise the Gleason system. A 5-point Gleason grading grouping, similar to those as PIRADS used with prostate MRI evaluations, was proposed to denote prognostically distinct stratification, right? So, and this is based on Gleason scoring system. Although when you develop the prediction model, you look at many other things that I'll show you later on. So grade 1 would indicate the lowest risk cancer, while grade 5 would indicate the most aggressive disease. The system was tested and validated against 20,000 prostatectomy specimens and at least 16,000 biopsy samples, so 36,000 samples. And a majority of the urologists and the oncologists who were the participants in that conference, they concurred on the superiority of the scale over the Gleason grading system. So now what pathologists do is they'll tell you the Gleason score as well, the Gleason grade as well. Grade means the differentiation, poorly differentiated, well differentiated, moderately differentiated. So the pathologist will give you the Gleason grade as well as the grade grouping, right? So this is how the grade grouping is done. 2 to 6 is not very serious, although 3 plus 3, you do call it a cancer, which we saw over here. Only individual discrete well-formed glands, because only there is one pattern, so you add the score twice, your score is 6. Now 6 is very sort of low-grade cancer, all right? It is not aggressive and you're not worried. Maybe you will not even give treatment for this one. You'll just observe, you'll decide for active surveillance. Then your second grade, so this is grade group 1. Grade group 2 is score of 7, where 3 is before 4, So what you see in this biopsy is that the most predominant pattern is the one that was assigned a score of 3, and then the second most predominant or common pattern was the one to which we assigned the score of 4. So it is 3 plus 4, the score is 7, but the grade group is 2. Now in the next biopsy number, this pattern was more common. So again, the Gleason score is 7, but the grade group is now 3. We have predominantly poorly formed, fused, cribriform glands with lesser component of well-formed gland, which was this one, the third pattern. And that is how you go on if you have got a score of Gleason score of 8, regardless of the patterns you see. This is grade group 4. And when your score is 9 or 10, we saw in the biopsy something like this, then your grade group is 5, right? And this is the most aggressive one, and the prognosis is not going to be good, unfortunately, and this might be more resistant to treatment, right? So here is, I've compiled a biopsy report, from somewhere on the internet, So what they had 12 biopsies. The pathologist received 12 containers with 12 cores, and they were obtained from apex and mid zone. This is the base, this is the mid zone, this is the apex. So from the right side, this is the right side, he took 2 core biopsies from the apex, 2 core biopsies from right mid zone, 2 core biopsies from the base, and the same from the left side, from apex, mid zone, and the core. And this is what he found, all were adenocarcinomas. And this was the percentage of involvement, core involvement, the percentage of the cancer cells that he observed or he found in those cores. But see, all of them are quite advanced. The Gleason score in container number 1 or core number 1 was 4, and 5 of the cores had a Gleason score of 8. 6 of the cores had a Gleason score of 10, which means here he saw only pattern number 4, no other pattern. Here in these 6, he saw only pattern number 5, the most aggressive one, and no other pattern. Here he saw a combination of pattern 5 and 4. Pattern 5 was more predominant. He has written major and minor over here. But see, perineural involvement, the involvement of the nerves, he's seeing them in 3 of the cores. And notice another thing, what he's observing is that the cancer is more predominant in the basal and the mid zone regions, right? The apex regions are not involved that much. This is an apex region. These 2 are the apex regions. So it is the basal and the mid zones that are involved in this cancer, both on the right side and the left side. Okay, base, right base, and here too, the basal regions, 90%, 60%. So this was discussion of the Gleason pattern and the biopsies. Now the next slide shows this enzyme, acid phosphatase 1 enzyme, which we do not measure routinely. It is not recommended, but some people say that ACP1 expression is a biomarker for poor prognosis in prostate cancer. It is also a biomarker of aggressive disease in colon cancer, right? But it is not tested routinely. The other tests are done, which are PSA and digital rectal examination, MRIs, biopsies, and we base our risk stratification on those things that I'll discuss in the next section. So what we have done so far is we looked at the utilization of MRI in prostate cancer. We said that it is very useful in certain clinical scenarios related to prostate cancer. We looked at the prostate biopsies, and we said that we now obtain more biopsies, and we said that rectal biopsies have problems like bleeding or hematuria or UTIs. So these days, the urologists, they use a transperineal approach through local anesthesia, where the probe is placed in the rectum, the ultrasound probe. Then we looked at different procedures for obtaining biopsies. We said that transrectal sextant biopsy is not used. We more commonly use extended biopsy, where we obtain 12 cores, and some urologists might prefer to obtain saturation biopsies, which is 20 plus, okay? Then histologic findings, there are certain histologic findings that cannot be seen in the biopsies that we discussed in one of the slides. Then we looked at the Gleason patterns, and we looked at how the Gleason patterns are combined to obtain a Gleason score or to assign a Gleason score. And then because of the problems in Gleason scores, we now have this International Society of Urological Pathology grading system, where we have got 5 grade groups. They are based on Gleason score. and number 1 is least aggressive, number 5 is the most aggressive, all right? Now, this is the TNM classification of prostate cancer, which is not as commonly used as the Gleason grading system. And this is for your reference only, so I'm not going to go through these, and you are not supposed to memorize this for the examination. But this one slide is important, this is pathological grading. This shows you the tumor burden, which we do look at for risk stratification. So, it shows you whether there is extra prostatic extension or not, whether the bladder neck is involved, if the patient has undergone surgery, whether the margins of the resected tissue are positive for cancer cells or not, seminal vesicle invasion of the adjacent structure. So this shows you a sort of tumor burden, okay, or the aggressiveness or the spread of the local spread of the tumor. Right. So this nodes and metastasis, that's again for your reference. Now we go on to risk stratification of prostate cancer, which is important. Risk stratification is based on the clinical stage and following pre-treatment clinical parameters: digital rectal examination, prostate-specific antigen, biopsy findings, and imaging study results like your MRI and bone scan, involvement of the lymph nodes in the pelvis or the inguinal region. So this is how you do a risk stratification. You take into account all these parameters. Pathological staging is a better prediction measure. It is determined following prostatectomy and the report from the pathologist. So we look at the tumor burden that I mentioned in the previous slide, status of surgical margin if the patient has undergone surgery, extracapsular disease, and seminal vesicle or pelvic lymph node involvement. So a lot of factors that we take into account to stratify the cancer and to predict the risk of metastasis if it has already not occurred, or response to therapy, or maybe also the lifespan. So these models can predict the time to development of clinical metastatic disease in patients with rising PSA levels. And again, there is staging is another risk stratification system. It has got 2 slides, but you don't have to memorize this. What you have to understand is that there are 3 things on which we are basing our risk stratification. And this system has been adopted by National Comprehensive Cancer Network in the USA. So what you take into account is the tumor burden, the size of the tumor or the invasiveness of the tumor, involvement of seminal vesicles, bladder neck, the prostatic capsule, right? And the number of lobes involved or extra capsule, extra prostatic tissue. So that is tumor burden is number 1 that you see. Then you look at prostate specific antigen, less than 10 nanogram, between 10, 20, or more than 20 nanograms. And the third thing you look at is grading group. So tumor burden, PSA level, and grade group of the cancer, right? And here I've given you the description of each stage that I've shown you, and this is only for your reference. When you go to your oncology clinics, you might need to read through these. So I'll skip through these, and you can keep them with you, and they are there in the handout as well. Okay, now just a couple of prediction models. Here are a few examples: prostate cancer nomograms that have been developed by Memorial Sloan Kettering Cancer Center. They are available at this website, so you can go to this website and you can put in the variables they are asking for, enter them, and get the prediction status. Okay, Parton tables updated by experts at Johns Hopkins, again used for developing prediction models. Cancer of the prostate risk assessment that we have discussed in one of the previous slides as well. You take into account the PSA level, the Gleason score, the tumor stage, the percentage of biopsy course positive, like I showed you in one of the examples, all the 12 scores were positive, so the prognosis is not going to be very good. The patient age at diagnosis. The younger the patient, the better the diagnosis, the prognosis. Then we have got this prostate cancer risk calculator, again available online. This is the link to that. And we have got some other prediction model in which we look at the genes, like this one, Prolaris. It is a sum of 31 cell cycle progression genes and 15 reference genes. So now you have got more extensive tests based on the facilities available in your hospital. You can get a more accurate prediction of the prognosis or response to treatment. 4K score in Rotterdam prostate cancer risk calculator, prostate cancer antigen 3, which is detectable in the urine. Then you have select MDX, in which you combine clinical parameters like prostate specific antigen, digital rectal examination, prostate volume, age, family history, and some genes. Then Oncotype DX genomic prostate score. There are 17 genes that you assay, and it is combined with CAPRA scoring system. Then you have got S3M, which is a risk model creating using data from Stockholm 3 study. So it looks at 232 genetic polymorphisms with protein biomarkers, right? So these are not available in most of the centers. So in most of the centers, your diagnosis and your prognosis and your prediction of response to therapy is based on your PSA levels, your Gleason score, and your grading group of the cancer, okay? And that is all for the second part. In the third part, we will go to the treatment, all right? So thank you very much. And I'll see you in the next section, or the next session, I mean.